Is that it? Okay.
Good afternoon. This is Steve Love. As you know, I'm here at the Hospital Council. I'm President and CEO of the Dallas-Fort Worth Hospital Council, and this is another continuing series of educational webinars that we do. We're very proud of our hospital members. We have approximately 90 hospital members, but we also have many associate members. And one of those associate members is Argos Health. And Argos Health really is your revenue cycle partner for complex claims. I'm still a recovering CFO. 11 years ago, I was in the role of a CFO. And let me tell you, these complex claims that you have to deal with really need expert handling, and it'll help your cash flow. But their business is to look at the billing and the resolution of these claims, and they pride themselves on managing some of these challenging accounts on your behalf that's going to help maximize reimbursement for the hospitals. Today's topic is going to be the VA hospital claims, and I think all of you know that sometimes they're pretty complex, and deconstructing the resolution process. And we're delighted that Argos Health has supplied us an expert speaker who's going to provide an overview of the VA and discuss some of the challenges, offer some ideas to improve the payment of VA claims. Our speaker today is Mr. Kirby Yon. He's Senior Vice President at Argos Health. He's a graduate of the University of Georgia. He and I were talking earlier, and we're excited about the upcoming weekend because it kicks off college football. And I lived in Atlanta for over 20 years, so I really appreciate the fact that Kirby is going to be our speaker today. His expertise is in business development. He also focuses on customer growth and also developing service offerings to help improve day-to-day operations. So we're really excited to hear his presentation. And so it's my privilege and pleasure to turn this over now to Mr. Kirby Yon. Kirby?
Steve, thank you very much. And I can't thank the Hospital Commission enough for wanting us to participate and to offer a solution. I believe we've got 30 plus folks that have called in to listen to the webinar. And I don't know how many people have ever hosted a webinar, but I can promise you I'm in my office and I'm flailing my arms around and moving back and forth, and I'm talking just like y'all are out there in a crowd. So I guess it's kind of funny to sit here and talk to you in space, but I hope everybody will find our topic today impactful. I hope you'll get to take away about 3 key points that you need to look for with regards to your VA claims. My goal is to start us at a very macro level about who is Argos Health. My next goal is to take us to the very micro level of getting into the true blue weeds of the VA claims, and then back us out to another macro level thought process on, again, the VA claims. And I would just encourage everybody, I believe if you have the little go-to webinar control panel pulled up, you should be able to use either the chat or the question feature over on the side. And I've got time slated for us to have a Q&A, but I'm also 100% comfortable if someone has a question right in the middle of what I'm saying, I should be able to see it pop up, or Steve and his team should be able to see it pop up, and we can literally stop on a dime, answer that question, and divert course. I mean, I've got an idea of how this webinar can go, but I'm not afraid to take it to where everyone really has some troubles if some of the things that I'm talking about have to make you think of comments, questions, concerns, inquiries, et cetera, et cetera. So I thought I'd start us off with just a little humor slide. I'm sure everyone on the call is familiar with Gary Larson, who, in my opinion, is a genius. He is obviously the artist and author of The Far Side. And when I started doing talks in HFMA circuits and associations and alliances all across the country, that was probably about 6 years ago now. And I chose this slide, and I thought, you know what, I'll put this in there, and then what I'm going to do is every time I go somewhere new, I'll probably grab a new Far Side cartoon just to throw in there. Well, here we are 6 years later, and this Far Side cartoon applied to that webinar or that speech 6 years ago, and it still applies today. And I just have to imagine that everyone that's listening in kind of feels this way about the rev cycle, right? We hear one day we do one thing a certain way. The next day it seems like we have to divert course. And so I've always found that this Gary Larson slide just really starts to hit home about what goes on in the day-to-day life of a rev cycle, business office manager, patient financial services employee, whatever you want to call them. But it's just, we're all being poked. One way or the other, we got to go in one of those doors. Little macro overview of who Argos Health is, so we'll get the homework kind of out of the way. As Steve mentioned, we're a complex claims company. We focus on pretty much exclusively 3 claims. We do a little bit of here and there with some other denial things, but our core business is the 3 complex claims of workers' compensation, motor vehicle accident, also called third-party liability, and then the VA claims. And the VA claims kind of came to us about, we're going on 6 years ago now, as a byproduct of we were just working a lot of the other 2 kinds of claims, and a hospital happened to raise its hand and say, would you be willing to take a deep dive and figure out what exactly can we do with this VA book of business that we just can't get moving on our AR? That caused just a snowball effect in our office of SOPs, what reimbursement should be, how are we going to implement a brand new phone system to account for the horrible wait times, what do certain denials mean that are specific to the VA? Heck, what in the world's HealthNet? What is this Tri-West thing? So these are our 3 core competencies. We like to say that we do one thing and do it well, and that is those claims that in your office just seem to really bog down your business office employees. A few little bullet points here. I'll make them kind of feed through the slide. There's a reason why you typically outsource complex claims to someone like us. There's usually a higher net reimbursement that exists. You usually see improved cash flow. That could just be the speed in which the claims actually get paid, or it could be the percentage of total charges you actually see paid on a claim. You've got reduced days in AR. With regards to our VA business, we can typically shrink those days in half. The one hospital success story I like to hang my hat on is we had a hospital that was averaging about 240 days in AR for their VA claims. We now run at about 109 days for that particular hospital. So some real success stories in the way we can reduce those days in AR. You've got reduced compliance concerns. That doesn't so much relate to the VA claims as it does the third-party liability and the work comp. And then we've got this little thing here at the end, the more time to focus on core competencies. And as we go through these VA slides, I want everyone to just please remember in the back of your head, one thing that happens when you remove a complex claim burden from a business office employee, you don't necessarily lose that employee. You should be able to increase their ability to work the claims for the higher and better reimbursing payers. So that's one of those benefits that we have a hard time quantifying because we don't know exactly where that business office is repatriated and then what the results are of that. But so far what we've heard from all the clients where we've gone in to work our complex claims is we've heard statements such as, wow, we can really get through so many more BCBS claims or claims, or our Medicare claim corrections have gone through the roof because we've been able to focus that employee solely on that instead of getting bogged down in the other nuances of those difficult claims. Last little slide about Argos Health at the macro level. We've got 3 locations right now, and y'all can, of course, read the slide just as easy as I could read it to you. We've got third-party liability, MVA, that operate out of Augusta, Georgia. We've got our Work Comp Center of Excellence in Hudson, Ohio. Corporate's in Dallas, so not too far from where a lot of you on the phone are from. Well over $400 million collected for clients. I'd have to run a number on it, but we could beat a 450 by now. A little over 100 FTEs. And then this last bullet point, again, when you're thinking about complex claims, the work we do typically account for about 5% of your total claim volume. The problem with that 5% is it probably makes up for about 80% of what you're going to consider the difficult claims you have to deal with. So, it's almost like the 80-20 rule, except it could be reversed even further to maybe 5%, 95%. But we definitely deal with the headache claims that seem to just bog down that rev cycle train that starts at registration. And we're going to learn about that a little bit in the webinar. And then it falls all the way through the rev cycle process. So without further ado, let's get into the VA. I'm going to start with a question, and I'm going to ask it, and then I'm going to pause for a little bit. So for everyone on the phone, would you call the VA health insurance? It's something to think about. When a veteran presents and they say that they have VA, does your registrar, does your PFS employee, does your biz office biller, do they consider them to have health insurance? The answer should be no. And what I'm going to do is I'm going to rely heavily on a few VA lunch and learns we've helped host all around the state. And when we have those, we get the VA to send down some of their employees. And I found it really telling that in the very first one of these we did, the lead VA employee, her main point was, just as an FYI, we're not health insurance. So if you were to go to that presentation we did, and the first one we did had about 7 hospitals participate. We did a 4-hour shift in the morning. We did a 4-hour shift in the afternoon. All those hospitals sent people from patient access, and they sent employees from the business office because we wanted to make sure that the revenue cycle train started and stopped. So in those 4 hours, we had all kinds of feedback questions to ask, but I cannot begin to tell you how this one statement of we're not health insurance pretty much had everybody confused from the get-go. So it's very important to know that the VA doesn't consider themselves health insurance, but they consider themselves a purchaser of medical care or services. So what they're saying is, we don't have any quote-unquote health insurance. We're not taking in premiums. We're not worrying about copays and deductibles. But what we are doing is that when our vet decides to have treatment somewhere, we're going to purchase that care from the provider. Now, that's pretty much the same thing that you would kind of think of when you think of health insurance, except there's a few key bullet points to think about when you say, well, no, it's definitely not health insurance. So you have to ask yourself, what are the major differences between the VA and some other payers that you have? I'd first like to ask, does anyone on the phone know if you have a contract between the VA, and by that I mean just your typical VA? Do you have a contract with HealthNet? And do you have a contract with TriWest? I'm guessing you might have a contract with Veterans Choice that was encouraged for you to sign maybe 2 years ago. You may not even have that, but if you were, it's a scary document they presented because it pretty much only said you're going to offer the service. It didn't go into rates. It did require you to give notification if the veteran didn't show up for their care, and you had to do that within 24 hours of the missed appointment. So it was a very one-sided contract, if I had to say what the contract was like. But if you think back through, you could probably email me right now a copy of your Blue Cross contract. You could email me a copy of your UHC. You could email me a copy of your Medicaid provider manual that would help to define how things are supposed to be worked. But you couldn't send me a contract on the VA. Another key difference between the VA and some of your contracted payers, what are your timely payment penalties? If you have one, I would love for you to email me exactly how you know what that is. But to my knowledge, you can't enforce a timely payment penalty with the VA. However, I would hope that every one of your contracts with the commercial payers, I'll call them, they have some sort of timely payment clause in there. If you can prove that you've got a clean claim, if you can prove that you've supplied the medical recs they requested, and all of a sudden the days go past around the 15-day to 30-day time frame of where you haven't received payment, you could threaten that payer with an interest penalty. That same sort of recourse doesn't exist with the VA. A question for the third bullet point, a question for folks on the phone that might be from patient access. When a veteran comes in and you register them for a service in your hospital, can you tell the VA's policy, the veteran's policy number and group number at time of registration? I don't think so. They don't have a standard insurance card that you might flip over and call. They don't have policy number, group number, and employer listed. There are certain little nuances like that that make all the things that we go through to make sure the reg process has its hard edits, its stops, et cetera, et cetera. Well, you can't really do that for the VA. And then my fourth bullet point is, do you have data from the VA to load into things like your contract matrix, your charge master, your clearinghouse, et cetera, et cetera, et cetera? So can you push a claim out, and can your Epic or Meditech or Cerner or whatever system it is you're using, can it go ahead and give you a real-time estimate of what the reimbursement's going to be? Could it go ahead and tell you whether or not you've got claim edit errors that you need to fix? It could if you've pushed it up against basically what Medicare says, but it's not going to be 100% accurate. So unlike some of the other payers that you've got a contract with, the VA just doesn't allow you to win in some of those technological advancements we've seen in the claims process. And so you've got a little bit of a black hole there where not only do your registrars not know what they need to fill in, your billing business office employees, they don't have a real easy script about how they're going to get claim resolution complete so that the payment can come in. So then we know that we don't have a contracted payer. We know that we've got some fairly large differences between what the VA as a payer is as well as against what our commercial payers are. So then you have to ask yourself, what in the world am I going to do? And if anybody's on the webinar that has a piece of paper in front of you, this is where you'd want to write down bullet point 1 that I need to take away from this webinar. And it's notification, 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 notification. You'll see in the next slide, there's another word that I'm going to stress 4 times. But if we went all the way back to day 1 when we started working VA claims to today's date, I cannot tell you how important notification is. And it's very important to understand notification is not the same thing as authorization. Now, I may sound like I'm really down on the VA. I'm not. The VA provides an incredible service for people that are doing things for us and our freedom and our protection. And the VA has a very good reason why they want this notification, and that's because it's the VA's attempt to try and follow that veteran through the course of care of the entire time of their life. That could be a little bit too aggressive, and that can they even conceivably do that? But that's their goal. And the goal for doing that is because when the veteran shows up at the True Blue VA-owned facility, they want to know what's happened before so they can make their treatment at their facility absolutely the best that it can be. So they've got good intentions for why notification is so important. It just places an extreme burden on you as the provider out in the open marketplace because you've got something you've got to do, and it's not this silver bullet that all of a sudden just makes the claim pay. But I can promise you, if your patient access team is not trained to notify your closest VA facility of when a veteran is in-house, whether it be through the ER, whether it be through a lab workup, whether it be through a scheduled inpatient service that already required authorization, if you aren't doing that, you are not going to get your claims paid in a timely manner. So I would encourage you, if you're on the call just from the business office side of this, schedule a meeting tomorrow to meet with your patient access team and say, we've got to get a handle on this notification process. And the good news is, per point 4 on here, you've got some time to do that. So your ER registrars Friday night at 10 p.m. don't all of a sudden have to make that phone call at 10 p.m. when the ER lines are long and there's some real traumatic things going on within the ER. You've got 72 hours to call in and let the VA know, hey, we either are treating at this moment or we have treated in the past few days a veteran, and here's the information about it. I'd almost encourage you that if it was the first thing someone from Access did on Monday in order to catch the weekend admissions, that would be a good goal. And then if you just had somebody that did it, let's say Tuesday and Thursday afternoons, you could catch yourself up. But you need to somehow block a time where notification can happen, and it can happen consistently. Now, the last bullet point does account for those third shift ER visits, et cetera, et cetera, et cetera. But you're going to need to call your closest VA facility, and you're going to need to ask them for the WIN number. And WIN just stands for weekend, holiday, evenings, and nights. And that's typically a phone tree process. So you would call in, you could select, let's say, option 3. You would enter in the information regarding the veteran, and then you could hang up and you could go on about your day. So it is something that, a Saturday ER shift patient access person at 4 a.m. could do for you, and they could pick up for a certain period of time in the past. But you should have you should have the ability to call and get that number so that you could just phone tree it, and you wouldn't actually talk to a live person on the times when the VA is not open for you to make those calls. So again, if you've got a piece of paper and if you're taking notes, notification is probably, if not the number one thing you have to take away from this webinar. The second thing you're going to want to take away from the webinar: authorization, authorization, authorization. If the veteran is coming for an inpatient episode of care, or there are labs that need to be done, you should be receiving authorization from the VA that it's okay for the veteran to come do that at your facility. Please know, this does not mean the ER episodes of care that turn into inpatient care. This is scheduled. This goes right to the heart of the Vet Choice Program, where it was enacted by the President and Congress that the veteran has a right to choose where some of these things are done other than an actual VA facility. Your authorization form most likely is going to come in fax form. It's going to have a QR code on it. So QR codes are just the modern day UPC symbol. But that QR code is going to drive everything moving forward as to how and when that claim is going to be paid. Because when the veteran comes in for these scheduled inpatient care or labs, you're going to need to submit the claim via EDI transmission. You're going to need to in turn follow that up with a transmission of the actual UPC or 1500 physician form, the medical records to go with it, and this authorization form. And unfortunately, I can't tell you that EDI transmission is going to get the claim paid every time. And I also can't tell you that the paper claim form is going to get the claim paid every time. But I can tell you that if you're not doing both, you're taking a true shot in the dark as to which claims are going to pay and which claims aren't. Now, if we move forward in time, and 2 months from now, we held this webinar again, I would assume someone's going to raise their hand and they're going to say, well, Kirby, I just got to tell you, a lot of my EDI claims are being paid and I'm not having to do anything with the paper. I'm not faxing the med regs. As soon as someone told me that, we would have another person in the audience raise their hand and say, look, I went all EDI and I can't get a claim paid. Why am I having, I guess I should just send all my claims paper. And it will be various pockets throughout the state of Texas that where hospitals are treating veterans that have the same VA as their home base. And just to date, there is no rhyme or reason why some claims are paying with only an EDI and some claims are paying with only an paying with EDI plus paper, and some claims are paying with just paper. If you're not doing both, and if you're not doing them consistently, then you are missing out on some claim. You're missing out on the ability to reduce those days in AR, increase your cash flow, et cetera, et cetera. So, kind of to my bullet point 2 right here on authorization, some of the care that the veteran needs can be done at the actual VA hospital. However, the veteran can request the choice to do it somewhere else. And a great example would be the VA might be 30 miles away, which is clearly within range of how far a veteran can be expected to drive for a treatment. But you may have a hospital that's right there in the veteran's hometown that is, highly recognized for cardiology, or it could be orthopedics or something else. And so the veteran could request to the VA, I really want to have that done here because, wow, they're really good at this. In that case, they're going to get approval and authorization to have that there. You just need to make sure in your scheduling department, maybe you build a little edit into your EMR that says, if this is a veteran and if I'm scheduling care, can I check the box that say I received this authorization? So just kind of like your typical commercial health insurance where you're trying to get an off episode of care, make sure you've got some really good parameters around when you're going to, where these auths going to come to, how are you going to post them, how are you going to know that it's been received. And I would really encourage those that have CBOCs, which are the community care centers that the VA placed all around the country. Lab work can get to be a pretty big deal for some facilities. We work for a hospital in Southeast Georgia. Their CBOC specifically does not do labs, but they treat veterans at the CBOC all day long for service-related injuries. However, in order to check on them, they'll need some sort of lab work done. That hospital just had to become really, really rigid on, the CBOC's about a mile and a half away, but they can't take that veteran and actually do what's going to happen until they have that authorization form in hand for what's going to be done. So we've got 2 bullet points so far: notification, notification, notification. The second takeaway, authorization, authorization, authorization. Get your hands around it as best you can. The third takeaway from the webinar, and this is the last takeaway, and then we're going to move ourselves out to another macro level, but this again goes to the beginning of the rev cycle process, and it goes a little bit to the end because we've got to do some searching, but you need to make sure that at Reg, your team has a well-scripted way to ask for, and I'm calling it primary payer information in this slide, although the veteran may see it as secondary payer information. My first bullet point, if you're sitting on this call from a business office, please schedule a time to talk about this with your patient access leader as soon as possible. And on the second bullet point, I've given a little tip for what the script could be. You can adapt that to however you want. I'm sure everybody on the call now has picked up on my extremely Southern accent. And so my quotation here of how you could ask for more information is probably way too Southern for some people's liking. But I think it's just very important that those patient access folks realize they've got to say something along the lines of, sir, ma'am, I realize you're saying this is a VA claim, but I'm just trying to help you so that in the event the VA doesn't pay, you could prevent this bill from becoming your entire responsibility. Now, you've got to run that past compliance, and I'm not claiming to be a compliance expert and whether or not what I've typed is, okay to be used. But it's got to be that sort of statement, because a lot of veterans, unfortunately, are confused as to what exactly they have VA coverage for. Because the VA is going to tell you they've got it for service-related injuries and then sometimes certain ER episodes. But throughout time, I think we've had a little bit of we've had some things working against us in the provider role, in that when claims are processed by the VA, there's a real big part at the end of the claim processing that's what I'll call missing, that exists in the world of Medicare, BCBS, UHC, etc. And that's the copays and deductibles. So claims that get processed by the VA don't have balances remaining that become patient responsibility. Well, our patient population has picked up on that. So, of course, when someone presents and they know one insurance is not going to leave them with copays and deductibles and the other insurance is, they would like to adamantly demand this is a VA claim. Makes sense to me, because I don't like patient responsibility when I have medical care. But I think you've got to be careful, because at some point in time on a lot of your claims, you're going to need to flip the switches to the other payer. Now, that's how the patient access team helps us. The business office team can help too, because in your business office, when you have a claim going to the VA primary, I would strongly encourage you to adapt a standard operating procedure that says that business office employee is going to make it a habit to look back in time to see if any other payer existed that paid a claim. Now, they don't need to go back through the entire patient record all the way back till patient birth, but I would certainly say if you're not looking 4 to 6 months back, then you're missing out on something, because what you'll start to realize is you'll find 4 months prior to today's date of service, a claim did get paid by Medicare. But lo and behold, on today's date, no one pulled that claim, that payer information forward for the claim that you're dealing with. Well, you need to get in that good habit, because that will start to clue you in, and you might see some things and you might see some patterns that allow you to really hone in on what are the service-related injuries or illnesses that the patient's dealing with versus which ones aren't. So those 3 points right there about primary payer information. Third in my line of what's important, I would again say notification is the easy one and possibly the most important. Auth and primary payer information captured at registration, I think, go hand in hand, in that you've got to start to adapt some ways in which you can find coverage you otherwise might have thought wasn't available. So after those 3 bullet points, there's a few more questions that we've got to ask ourselves and just some discussion points. And I would imagine if I was a business office manager, patient financial services director, you kind of throw your hands up, because you can say, well, I'm pretty good at those 3 bullet points you got on your slides, but what about all this mill bill, unauthorized care, all these? What am I going to do about that? So I think in order to develop a game plan around that, you first got to figure out, well, what exactly is the mill bill? And so the mill bill is an act that was put in place, and you can read the definition here, but it does allow you to treat for emergent care for non-service connected conditions, provided that all the criteria for reimbursement are met. Now, I'm going to leave it up to you, because we could go through just hours of what are the criteria for reimbursement. But, things like patient has absolutely no other insurance that could pay for this. Well, that's part of the Millennium Act, because they want to make sure that the VA is the payer of last resort. But when your business office team is handling your VA claims and they get denials that say, well, we're pending mill bill ruling, what you're hearing is the VA is trying to decide if, per the Millennium Act, they should pay for an emergent episode of care, or should they push that to patient responsibility, or should they say, we know something's going on where there's a primary payer out there and you should bill it to them. Again, kind of going back a slide, I'm going to move the slides back in just a second. If your team is hearing mill bill, this slide right here for primary payer information becomes of paramount importance, because you hope you've put in the processes to say patient access was a little more stern in asking for that secondary/primary payer information, or my business office team has gone back and we did see that 4 months ago the patient had Medicare. And that way, when you get this mill bill ruling denial or just update from the VA, you'll actually know that you have some choices that exist. So what about unauthorized care? So it's very interesting, but unauthorized claims can be paid by the VA. Now, what's really interesting, and I don't know if my mouse cursor shows up on the webinar, but the unauthorized claims procedure allows the veteran's representative, the hospital which provided the services, or a person other than the veteran who paid for the services to present a claim for payment of a non-VA medical service that was not authorized in advance. So it's really interesting that unauthorized claims, a veteran could come to your facility, they could have treatment. Kirby Yawn from Georgia could write you a check for their care, and then Kirby Yawn could actually seek reimbursement from the VA for that veteran's care. Now, if you're Kirby Yawn, you probably don't want to do that, because if you knew the percentages, you're probably not going to get reimbursed. But the VA does allow for some unauthorized claims to be paid. Now, we've had plenty that do pay, and we've had plenty that have not paid. This gets really tricky when you start to deal with VA facilities that are on diversion. So that VA facility may be full, and so they're diverting patient traffic to your facility. You might be accepting some unauthorized care that you could get paid. You just got to be diligent in how you present to the VA that, well, it was because of diversion while we had to take them, et cetera, et cetera. You might be dealing with veterans that have further than 80 miles to drive to get to the actual federal facility. In those cases, you might be dealing with some unauthorized care that actually will be paid just because it wasn't convenient for the veteran to get to that location. And particularly when talking about the diversion, it's important to note the payment's only going to be made to the point when the patient was stabilized. So you've got to get really good, if you're in one of those diversion hospitals, that you do everything you can through the means available to you to get that patient in that facility ASAP, because you're only going to get reimbursement through the point of stabilization. So Argos Health, we're going back to macro, and you can read this yourself. We've got experience across all of the VA products, again, traditional, Vet Choice, Health Net, TriWest, et cetera, et cetera. We fully take off of our clients the burden of verifying claim receipt. We take off the burden of the paper transmission of the claim and the MedRecs and the authorization form. That goes hand in hand with the other complex claims we handle, comp and TPL. Those are still in the world of paper claim. So the VA just fits really nicely in that, like I said before, EDI transmission is not going to solve your problems. All paper claims is not going to solve your problems. We're offering total claim resolution. This goes to the slide of the primary, secondary, or payer. We take claims every day that are assigned to us because they are, air quotes, VA claims. However, they quickly divert course to a BCBS, a Medicare payer. And then we handle resolution through that payer as well. So what we don't want to do is we don't want to interject the problem VA claim that all of a sudden becomes a BCBS denial back into your business office employees' work queue. They have enough in queue, and then they'd have to all of a sudden catch themselves what has happened to the claim so far. So we take them from day one, and we give them back when they're either zero balance or patient responsibility, and we're willing to work whichever payer becomes the payer that's going to pay, and we provide whatever they need, all within the hospital's computer EMR system. So So we're willing to work just hand in hand, just as an extension of the business office. We do have proprietary phone capabilities in that we're able to utilize some technology that what we've found hospital IT departments just aren't willing to move to the forefront of what's needed. And what I mean by this is we can allow our VA employees to work usually around 4 to 5 times the amount of claims a typical business office employee can per hour. That's including the limitations the VA puts on us in that we can only call between 8 a.m. and noon, and we can only ask about 3 claims at a time. We've just been able to say, well, if that's how it's going to be presented to us, we've got to put ourselves in the call queue more times than just I pick up the phone, I ask, I hang up, and I start over. And again, this last bullet point goes back to my second or third slide, in that it allows for the reallocation of experienced staff to be more productive business office, to work towards more productive business office projects, a la if your business office team has 1,500 commercial claims in queue on any given day, what if you could throw some or all of another employee's time at it? You would get paid more by a quicker, higher reimbursing, better payer that you could actually hold to contractual obligations by reallocating that staff person somewhere else. So just a little before and after of what facilities have seen when they choose to outsource the VA claims to us. And again, y'all can obviously read this just as well as I could talk to you about it, but the productivity downtime while the employee's sitting there on hold waiting for the queue to hit. Now they actually, the hour that they're working, they're able to work through claims. Our technology allows us to work, again, 4 to 5 times the amount of claims they typically could have in an hour. Our facilities typically go from high days in our AR, as I mentioned before, around that 240-day example, to now they're running, 109 days in AR. And we've got various results depending upon what makes up the population of that facility's veterans, their total claim population. They're not all over 240. We've got some hospitals that were at, like, say, 160, and we've been able to work them down to that 70 to 80-day range. Before someone typically outsources these VA claims, they've got 10 members that are working on various payer types. So, you're kind of, to use a boxing term, bobbing and weaving between BCBS, the VA, now I'm going to work some Medicare maybe, or et cetera, et cetera. They're able to focus those employees' efforts on a true blue one payer system so that they can get really good at the denials that are coming from that particular payer. And then before outsourcing, you've usually got a trial or error. Well, I'm going to try this today. I'm going to try this tomorrow. Kind of what I talked about before of it's going to come at me a bunch of different ways. So what should I really put into place? So our team that works VA claims for our company, they only work VA claims, and they are good because the VA can't throw anything back to them they haven't heard before. Now, looking at my clock, we had scheduled that I'd go to 1:50 and we'd start some Q&A, but we can certainly start with that Q&A now. As this conclusion sheet's up here, I don't want to say let's start the questions and then me talk anymore, so I'll say just one more point, and it's this last little part in blue. If you're on the webinar and listening and you like those 3 points, I would encourage you to go out to our website and download this white paper right now, because what it's going to do is take those points and more, and it's going to explain the VA claim process to you. And I have to give a little bit of credit to a meeting I had with Jim Hoffman, who's our COO, and I think he might be on the call somewhere, but we were trying to come up with a really good title for what would we call what we do for VA claims. And I love to eat. And so I always like it when a chef says, well, here's our deconstructed egg salad sandwich. And, instead of the egg salad sandwich being all mixed up and together in between 2 pieces of bread, they've taken each one of the points and they've put it on a plate, and you eat the egg salad sandwich from ingredient to ingredient. Well, what we've tried to do in this white paper, and again, please, there's a world of knowledge in there that you could get if you just downloaded it and read it. We've tried to take that claim that exists on the UB or the 1500 form, and we've tried to break it down and deconstruct it into the things you can do to really make that claim get paid. So, Steve, I don't know if you and your team have anything to add here at the end, but I can certainly open it up to Q&A.
No, the one thing I would add is I think that was an excellent presentation, and I think you really have a good solution for some of these difficult VA claims, and especially with a lot of the regulations and some of the follow-up and follow-through. So I'm hoping we'll have some good questions that will come up, but thank you so much. That was a great job, Kirby.
Absolutely. If we're through with this one slide, I will hit advance one more time because this just has our contact information. And anybody on the call is welcome to email, call, carrier pigeon, however you want to get in touch with Jim, myself, or Palmer. We're not afraid to answer questions, offer advice, et cetera, et cetera, et cetera.
You got your first question, it looks like. The question is, what are the implementation fees and cost for your services?
0. So to get up and running, we don't charge a set fee to say, well, it'd just be X for us to get going. A couple of points. First and foremost, we like to work within your already established EMR. So we believe the hospitals have the Ferrari as far as getting claims out the door. Argos Help certainly has our own proprietary software that we use in order to help us work the claims. But you've got the Ferrari going. We just want to establish work queues, workflows. We want to work with you however best that you could assign us a batch file a day, and we could take those claims and then we could start working them for you. We operate on a contingency fee basis. So if a payment comes in on a claim that's assigned to us, we just charge a percentage fee. We work plenty of claims every single year where we do every single thing we can to get them paid. And this is in the work comp business, and the TPL business, and the VA business. And it's just not going to work out, and it's either going to be fully patient responsibility or the hospital made an error and it's uncollectible. And for all that work, we charge 0. But if a payment comes in, we charge a percent of what was paid. No startup cost, no conversion to an hourly attorney office, nothing like that.
There's another question. I don't know if you can see the questions, Kirby. It says, we are a small critical access hospital and don't have as much large volume as others. Is there a minimum volume that you require?
There is not. In fact, I don't know a good way to do it through this webinar, but at va.gov, there is a great map tool where you could pull up the state of Texas, and they use highlighting features from white to red, and red is the most dense areas of veterans in that state. And they do that for every state. Well, in the state of Georgia, we work for a critical access hospital that just happens to be in a really red shade. They are critical access, and they assign to us just under half as many VA claims as a 2-hospital system with a total of 300 beds. So I say that to again reiterate, nothing's too small and nothing's too big. Happy to do it wherever somebody wants us to work.
Here's another question. Is the notification process standardized throughout the VA?
In theory, it is. In practice, in pockets, yes, and then as soon as it gets, on the edge of that pocket, it won't be. Now, remember, where your VA claims go to get processed is not dependent on where you are as a facility. It is dependent upon where the veteran lives. And I say that because for most facilities, 60% of the time it's going to work every time, because you're going to see a batch of patients that a main VA facility is the payer, but you're going to get some outlier patients that live, let's just say, on the opposite side of town. Well, there's nothing saying that their VA facility would be the same as the bulk of your patients. and they may have a little different way in which you need to notify. You should be able to get the WIN numbers, and for everybody, I'll just run back to the weekend, holiday, evening, night, and you should be able to pretty much always call between 8 and noon to give that notification. You're just going to see some various idiosyncrasies as you go between VA facility to facility. One little quick aside on that, we do work for one facility. They get payments from 4 different federal VA facilities because they are in this piece of land that pretty much seems to be 80 miles from any one of those 4 payers. So their claims start out going just as general practice to one main VA facility. That facility is supposed to divert their claims to the other payers, but our follow-up for that facility could lie at any one of those 4 payers where their claims go to.
Right. Now, Kirby, I bet you've heard this other question before, but here's a note and a question. Notification is great, but how do we get the VA to acknowledge our notifications? They don't answer the phone, and they don't return our phone calls.
The good news about that statement is whoever asked it, just be happy in the fact that you're not out on VA Island. You're not existing in a problem that is specific to you and no one else is experiencing. Everybody says that. And in those, this is the best advice I can give. I think you have to go to your C-suite or your public relations department or someone like that, and you have to say to them, look, we've got to break down this wall between the VA. Let's go pay them a visit. Let's go up and say, we just want to meet and we want you to tell us what we're doing wrong. Last week was North Carolina HFMA in Myrtle Beach, South Carolina. And I took a call from a hospital that week, and the business office manager on the physician side just wanted to know, hey, can you just get me in touch with someone? And I introduced them to my main contact in the area that helps our claims get paid. But my introduction was along the terms of, the hospital definitely feels like they must be doing something wrong. They'd like to meet with you to work that out. I would just say you have to start to establish that relationship. And I'm kind of assuming that it's broken down, and it may not be broken down in your eyes as the provider, but I can promise you establishing that relationship, going to the C box saying, we want to treat, we're here for you. I guess in the South we call it maybe eating a little humble pie that you don't always want to, but you've got to get your relationship back up. That's the first and foremost.
Here's another one, Kirby. It says, we're experiencing that our electronic claims are automatically being denied for the medical records. We then submit the medical record with a paper claim. Then this is denied as though it were another electronic claim. Have you ever experienced this, and why?
Yes. So you're not going to like the fact that I'm going to say your EDI is not necessarily being denied for medical records, but it's not so much as being denied for MedRecs, but your EDI is not paying because they want medical records. Now, I think the person asking the question could say, well, we already do that. But I would go back to, one, make sure your notification process is bulletproof. And if it is, before you submit the MedRecs with the paper claim, have someone verify claim receipt with a claim number from the VA. Then when you go to transmit the UB or the 1500 with the MedRecs, write that claim number on the actual claim before you hit send on the fax machine. I'd also encourage you to make sure you reach out to that VA and ask them exactly how they want to receive the claims. And you might learn, and we did this, we had a VA facility that said, we don't want to deal with the fax machine anymore. If you just send them to us via mail, it'll get taken care of. lo and behold, that worked. Now, I don't like it because it costs us more money, and remember, we're only charging a percentage of what we collect, so that eats into the cost to work a claim that we have to worry about. But I think you can get through that problem 3 steps. 1, button up the notification system and make sure it's absolutely perfect. 2, verify claim receipt and claim number before you send the MedRecs. And 3, assuming it's a VA facility where you can actually talk to a person, just give them the chance to tell you how they want it received and walk through that process with them. I'm sure there are plenty of people listening that say, I've done all that and it's still not working. That is the unfortunate world we live in, and that I can offer these suggestions, but I make no guarantees. But that's a pretty good start. And I'd say through the experience of the claims that I've been involved with to work, and then the feedback I get from my VA team, just double check to make sure that notification and then authorization process is right.
Here's another one, Kirby. We do ask patients and are diligent about requesting any other coverage. Some are very adamant about you will bill the VA, and that's the information I've given you. So we bill the VA. It takes sometimes up to 18 months for the VA to decide if they're going to pay, and when they decide they're not, we have then missed other billing deadlines for other coverage. Any suggestions?
This last bullet point, and Steve, I'll ask you real quick. Can you and Chris see me circling with my mouse this bullet point?
Yes.
Okay.
Yes, we can.
Okay, perfect. So the person asking the question, this is kind of the first step. Just make sure your business office can look back and see. I also might suggest that if your compliance team is up for it, and if your COO, and if y'all are willing to do it in patient access, could you come up with another form that the veteran has to sign off on that says, I, Mr. or Mrs. Veteran, acknowledge I'm not providing you any other insurance, and should the VA deny this at any time, I admit this is my responsibility. Now, your patient financial responsibility form or your patient admission form, assignment of benefits may already have some language that's kind of generally around that. What if you had one just for the VA? I don't want to try to be the type of person that's saying you need to push people away from treatment, but and adding one more piece of paper to the reg process is sometimes looked upon unfavorably. But if you're asking that question and you're from a hospital with a large volume of VA, AR, or just the dollar value is really high, give it some thought. Make them sign off on that, because that is the number one problem we hear when we go to folks that say it's just taking so long, and then before I know it, we've already passed the Medicare deadline and we can't bill Medicare because it's timely. I know. So somehow you've got to break that barrier down.
Right. Here's another one. The VA facilities in my area are always full. However, they will not say they are officially diverting patients who then come to us.
Yeah, that's tough. So I live and work in Augusta, Georgia, and across the street from my office is a level 1 trauma center, and it is connected by a 100-foot bridge that goes over the street to the VA hospital in Augusta, Georgia. And that hospital deals with the exact same thing. Now, I believe, I'll just skip real quick and I can answer this one without dragging it out. I don't know an answer to that. I would go back to make sure y'all are having meetings and trying to get that relationship established. See if you can't help someone at the VA in the upper levels of the actual clinical facility understand what's going on from a revenue perspective, and see if you can't get that worked out. You could go into the unauthorized claim scenario, so it's not that your claims won't get paid, it's going to be an uphill battle. But I would just go back to that relationship building.
Okay, good point.
I don't have a good answer. That's a tough one.
That's really, and I know the hospital people know this, that's really up from revenue cycle management to the CEOs and the COOs collaborating with their neighbors, as your example gave, on how do we work through this. And hopefully you can get more at the policy level and at the executive level an understanding of how you're going to handle that.
I think that's absolutely true. Absolutely true, Steve.
Good. The VA hold times that we are experiencing last over 2 hours. Is this common, or is this happening in other parts of the country?
It happens everywhere. And I would assume the same person that asked that question gets some sort of feedback from their employees that says, and not only did I wait 2 hours, I asked about 3 claims, and then I had to hang up and call again. And that's where I spoke about right here, this proprietary phone capabilities. I think you're going to have to test the temperature of your IT department. And are they going to be willing to take the next steps to allow your employees to have what they need in phone capabilities to ask about more than 3 claims at a time? And if they're not, you're stuck.
Kirby, here's kind of a question. I'm not sure what they're trying to tie it to, but it says, does what you cover include Champus/TRICARE?
It certainly can, but if you've got a Champus and TRICARE problem, I'm not one to ever turn down business, but I might try to talk to you about why that really is a problem. Champus and TRICARE operate more like traditional health insurance. So it could be that you've got more of a reg problem in is someone confused on what Champus is versus VA Health Net, TriWest, et cetera, Vet Choice.
Right.
We don't typically have a problem with that payer. If whoever asked that question, if you're still on the webinar, you've got mine, Jim, and Palmer's email address. If you want to shoot us an email and say, I want to talk to you specifically about what's going on, I would love to know a little more detail into that so I could possibly help with just some macro level thoughts, and you might have a resolution, within your own facility.
Right. Kirby, this one's a little more pointed. I hope you take it in the spirit it's given. It says, we really appreciate what you're telling us, but you're not really telling us anything we don't already experience daily in dealing with the VA. So specifically, does your company do notifications as well?
We have not gotten into the notification process, but I would say we're not afraid to. So far, none of our clients have requested that of us. But if you want to assign VA claims, the second that quote unquote discharge happens so that we could actually take that over, we just establish SOPs around the assignment of your business to make sure that takes place. I've typically found that's been able to be put into place by patient access, but happy to discuss that further.
Great. And here's more, I guess, a comment than a question. I've been to the VA on multiple occasions, met with them. They promised me the moon. As soon as I leave, it's business as usual. So I think that's more of a frustrating comment that goes along with everything else we've said.
I think that is a frustrating comment, and I would just go back to this point right here. If you're getting nowhere and you're still throwing built-in overhead at it, salary, payroll taxes, IT, there's a cost associated with the space that each one of your employees maintains. If you're throwing overhead at it and it's not resulting in a payment, well, why not outsource it to me? Because I'm only going to charge when there is a payment. I could work a claim for 6 months and end up charging zero because it never paid. I think that's where that reallocation really becomes a true benefit that I can't put a number on. But if you could work 10 more United Healthcare claims in a day through your business office, you would see an uptick in cash flow that you weren't realizing right now.
That's a good point. Here's another one, Kirby. We cannot get a dedicated rep or claims processor assigned to us. the rep that we were finally given works as a liaison, really doesn't answer calls or emails. So if we engage you, how are you getting these claims paid?
I'd say in a situation like that, it's because I'm willing to just throw the bodies and the repetitive phone calls at it, et cetera, that you might not be able to do in your office, because I've got folks that only work the VA claims. They don't have to worry about a stack of BCBS or Medicare claims or recoding, for those other payer claims. They're only going to do this one thing. And a lot of times, are you utilizing the VIS system that lets you check it online? A lot of folks don't even know about that. Well, if you don't, you might want to go there first to see if you can check online. And the feedback I've gotten from our team is that the VIS system is good. It's not great. So you can get claim detail through the internet, almost like a payer portal. Are you using that? I'd check to see if you are.
Right. Kirby, I don't think we have any other questions, but I have one from you. I tell you, I'm still a recovering CFO, so don't hold that against me. But one of the things that you really impressed me the most is at the very outset of your presentation, you said make sure and check with your legal counsel and with your compliance officer. So I have to ask this question, and I'm sure you've been asked it before. Since your fee is on a contingent basis, and this is a government program, have you had any problems or pushback from any of the providers, legal team or compliance officers, that they don't like to pay outside consulting firms on a contingent basis of a government claim?
Zero.
Okay, very good. I just wanted to bring that up because I know you have a lot of providers you engage with, and that's good to know. I think Chris is telling me we have one other question. Hang on a second. Are your fees? What are your fees on paid claims? I guess what they're asking, Kirby, is what is that contingency percentage?
I'd need to shift to an individual conversation with that hospital representative, because as you can probably imagine in the contingency fee world, the hospital in the middle of Dallas that has 800 beds has a different consideration for contingency just based on volume versus, let's say, the person that asked the question that was a critical. And that takes into account looking at the map and those dark red sections, like I told you about, where that one critical access hospital was almost as busy as a really big facility. They just happened to operate in two different pockets of the state. So we can have those conversations on an individual basis with the hospital. Okay,
I think what that really means to the people here, you heard what Kirby said. Even if you're a critical access hospital and have low volume, he's going to work with you. But the fees obviously are going to vary based on volume, and that's really between your individual conversation with him and his team. I think that's all the questions. I think that's all the questions, Kirby, but on behalf of the Hospital Council and behalf of the people here on the webinar, this has been very insightful. It's been very well presented, and we are most appreciative of Argos, of your support, and really of this work you're doing in the special claims handling. And, again, going back to when I was in a hospital, your point's well taken. If you work all the VA claims, and even if I don't collect hardly any, but I then can free up those resources to work other claims, it's obviously going to help my cash flow.
Well, Steve, I thank you and your team. I think all the people that actually got on the webinar, and especially those that stayed on the webinar the entire time. Let us know how we can help. We're here.
Well, thank you very much, and I hope everyone has a good day. We're signing off.